All right, so welcome everybody. We are talking today about direct-to-consumer genetic testing for healthcare professionals. We are the Intersociety Coordinating Committee for Practitioner Education and Genomics, the direct-to-consumer genetic testing project group. My name is Haria Ayubiye. I am co-chair of the project group, and I will ask our panelists to introduce themselves. Dr. Tracy Wheeler is also a co-chair of the direct consumer project group. So please, Dr. Tracy Wheeler, go ahead.
Hello, I am a genetics educator at Florida International University in Miami. I teach the medical students genetics throughout the first 3 years of their medical education, primarily. Mylinda, would you like to go next?
Hi, I'm Mylinda. I'm a family medicine physician with a PhD in molecular biology and genetics. And I work primarily on integrating genetics and genomics and precision medicine concepts into the primary care space, education, and translational research for precision medicine. Thanks for joining us. Kathy.
Hi, nice to meet you all. I'm Kathleen Blazer. I am the Director of Cancer Genomics Education Program at the City of Hope. It's focused on the genomics of cancer, and also the focus in our division is to work mostly with providing education and training resources for practicing clinicians. And I'm also a genetic counselor, but no longer in clinical practice. But I would like to introduce a stellar genetic counselor next. Rachel.
Thanks so much, Kathy. My name's Rachel Mills. I am a genetic counselor. I'm an assistant professor with the UNC Greensboro Genetic Counseling Training Program. There I oversee the research and capstone coordination. I also have an interest in direct-to-consumer genetic testing based on some research that I did in a previous role at Duke University. I also have been a customer of direct-to-consumer genetic testing. And as a genetic counselor, I know that this is a great entry point for some of our patients and for the general public to learn more about genetics. So it's a topic that I'm really interested and committed to, and excited to talk to all of you about it today. Thanks so much for joining us.
And I actually forgot to introduce myself. I'm Haria Ayubiye, and I am an internist and a clinical geneticist at Texas Tech University Health Sciences Center in El Paso. And so without further ado, let's start the discussion. So Kathy, would you please tell us a bit more about direct consumer genetic testing, different types of testing, and maybe benefits and limitations?
Sure. So I'll just kind of start the conversation with what many of us certainly already know, and as Rachel alluded to, probably many of us have done and or gifted, which is direct-to-consumer genetic testing. So we're going to just kind of set the tone by saying what are some of the distinctions between this type of testing and other types of genetic testing that's out there. So basically, simply, this is the kind of genetic testing where you can just, without going into a blood draw, without involving a healthcare provider, without involving health insurance or authorizations, and certainly optionally not involving the medical system in any way, you can get genetic information about yourself and or family members or other members, people. And so it's a very kind of direct to the lab and back to you loop that allows you to get genetic information, and increasingly more and more of that. So what is the distinction? We want to make a little, maybe if we want to advance the slide. So at the top of the column, you see of the table, you see what we're talking about mostly today, which is this issue of direct-to-consumer testing. We don't involve a healthcare description. The consumer themselves is the one that decides and orders the test. Generally, this is done online. The consent issue is one that we're very concerned about, and we'll talk about quite a bit today. And in that setting, most of the time it's written word, again, mostly online, sometimes accompanied by short videos to give you information, and you can click and consent. And any of you who may have done that will certainly know how simple that is and to what degree you're actually engaged in that. Understanding what you're consenting to might be very highly variable. And then who discloses the results? Well, the result comes back from the company and the lab directly to the consumer. Again, this is usually done electronically. So the consumer themselves gets that information and looks at it and may interpret it in many different ways, and or may at some point share that information with others, possibly also engage the medical community in that process. But that's a highly variable thing that is completely under the control of the consumer themselves. The second category is provider mediated. And this is a very variable type of area that has emerged in recent years, where there is some involvement of a healthcare provider. And that is really where they might be part of just ordering the test. They might be helping mediate what type of test is done. Again, very highly variable. And the consumer usually initiates this process, although their healthcare provider in-house may have said that recommended it, and then they go out and they outsource and get this care. The information does sometimes involve the involvement of a healthcare provider with the informed consent. And then the report is often directly given to the consumer, and they have the option to engage that healthcare provider system or resource again to interpret those results. But again, it is in the control of the consumer what that, and most of the time, as to what degree they engage the healthcare provider and expert. And of course, the bottom one is the standard of care. This is where most of us live. This is where we're most comfortable. And again, this is all kind of really focusing on health-related genetic information. And so this is where it is really facilitated by experts like Rachel Mills, who is a genetic counselor and or a geneticist might be involved, where it really is helping facilitate what kind of test is ordered. They order the test results go back to them, and then they share it with the patient or the consumer. And then the healthcare professional is also very much engaged in the informed consent process. And so it's mediated through healthcare professionals pretty much every step of the way. And then of course that gets integrated into the healthcare system, their health records and so on. And the other two might, but that is really directed by the consumer. So that kind of gives you the overview. So quickly, I know we're going to visit this a lot later on through this talk. So
could I interrupt you for a second? Yasin Ismail has a question. It looks like provider mediated is very similar to clinic based. Both of them are ordered by healthcare professionals. Why are they separated in different sections of the table?
That's a very good question. I think we could all share in this this response to this. And a lot of it has to do with how it's initiated, what the purpose of it is, and then it's really outsourced. So you're not doing it generally within the context of that given hospital or practice setting. And even if you're engaging, that healthcare professional maybe be someone you've never had a conversation with, that you've never seen. And sometimes it can be as minimalistic as them just, the test comes in as an order from the consumer, they sign off on it just ad hoc. And there's never a conversation or communication between that person ordering the test and that provider. Anybody else have anything they want to clarify further on that issue?
Yes, I actually had experience with provider-mediated genetic testing because I was curious. So you actually, so you request the testing, you request the genetic testing, and then you get an email telling you that a physician so-and-so would like to verify why you would want to get the testing. So I would just put in a chat box why I thought I needed this genetic test, and then they approved it. And I don't know who that person was. They didn't really take my history. They didn't get any clinical information from me. They just approved it. And you know, the provider-mediated genetic testing, the provider was this physician was through the genetic testing company, right? So I went to the direct-to-consumer genetic testing website. I ordered the test, and they said this physician is going to review my request, my order. So that separation between the company and the physician or the genetics professional, if it's a genetic counselor, it's not really there.
Which brings up a whole a lot of issues, right? A lot of questions, I could say. So thank you. That's an interesting experience you had. Oh, so we might as well go on to the next slide unless there's, oh, I see there's another question. Did the test require physician approval because of the payment? Yeah, so why do they engage the physicians? And I think that I don't know, did you engage your healthcare insurance for it? No. So I don't know that that's the reason. I think that because it's highly variable, there's a lot of different ways it's being used. And increasingly, there's a lot of involvement with using this kind of hybrid model, right? So, it can be more mediated by your internal, physician as well, depending. Linda, do you want to add something?
Yeah, so the hybrid model, the physician mediated direct consumer testing, one of the ways that it's distinct is we have general direct to consumer testing, which has no physician involved. And for the most part, this does not have FDA approval as clinical grade testing, meaning that it cannot be used for clinical decision making. We are going to present one caveat to that later in the talk. And then the clinically mediated testing, so always mediated through a provider, is clinical grade testing and obviously can be used for clinical decision making. And then the hybrid model is actually clinical grade testing. And so the physician mediated aspect brings all of the labs tend to be CAP and CLIA certified, but the physician order brings it up to that clinical grade of testing and then can be used and does not need to be repeated or revalidated on the clinical side when the result comes back. So we're seeing this in medicine in a lot of different cases now. You'll see commercials for regular lab tests and even pharmacy mediated online pharmacies. And this is the genetics version of that.
Thank you. That's a really important clarification. Thank you for making that point. So I'll just move on real quickly to just overview some of the overall benefits and limitations, and then those will be better illustrated through the talk. So the benefits are obviously things we were talking about. This is in our faces. It's in everybody's face. It's like, it's entertainment even. And so we know these kinds of tests are now being ordered as gifts and as part of parties. And yet that's all lovely and fun. But the other part of it too, and this is something that Rachel is very impassioned about, is the fact that this has taken the word genetics and the concept of genetics and made it a household word, and also taken away some of the fear and the trepidation many people have had about genetics. And so this is actually a wonderful benefit for those of us in the medical community if we can harness that awareness and make sure it's used in an informative way. And so I think that that's a really important benefit. It's easy, it's very inexpensive. It's, you spit in a tube. It's very increasingly inexpensive, and you don't have to engage the healthcare or the medical system. And so that also kind of can give a sense of privacy about the fact that they're not as worried about potential genetic discrimination because of health insurance issues and so on, which may or may not be valid, but sometimes that's part of the decision making, as we've heard from our patients in the past. Obviously, this is information. Information empowers. And so it allows the consumer to take into their own hands, learning more about a lot of things, amongst them being possibly ancestry, health history, which is, again, the biggest factor that we're mostly focused on for today's talk, health information, health risks, carrier risks for recessive disorders, paternity, understanding, learn more about paternity. Again, then getting into the lesser challenging issues from the standpoint of health. We talk about sports, fitness, nutrition, which may or may not consider to be as valid as some of the claims make. And then benign genetic traits, which are the fun things like, can you roll your tongue, and how does wine taste on your palate versus someone else's palate? And so these are kind of some of the things that are nice and beneficial about being able to do this on your own. Limitations: the testing method is very limited in terms of what's done on these non-CLIA approved tests. Often these are targeted using small nucleotide polymorphisms. So they're targeted at certain segments of the DNA. So you're not getting the full spectrum of potential alterations in the genes or in the genome that could be confirming risk factors. And as a consequence, that information can be very misleading. It can give people false assurance. We've certainly seen that in our setting when people come to us with information saying, well, I've already done that test and I don't have this risk. And that they've looked at 2 or 3 little tiny bits of the genome, and it's nowhere near a definitive test for that risk factor. Potential overburden to the healthcare system by virtue of misinterpretation of test results in the setting where very often this information can be used and go to a third party, and that raw data then gets interpreted, and sometimes those interpretations can be very challenging, very confusing, and lead people to think they have risks they don't have. And in some cases, the healthcare provider thinks that those are real risks and they're not validated. So you need clinical confirmation, as Linda was saying earlier. And the concerns about privacy and use of data are not trivial, because unless they know how to walk through and ask the right questions, there are a lot of caveats to where this data might be housed and how it might be used and with whom it might be shared. And so we talked a little bit about informed consent, and one of the key factors in terms of just standard of care approaches, in a little bit more with the hybrid approaches, is that informed consent can help address some of these concerns. And so when you have full informed consent, the genetic counselor or the healthcare professional is trying to bring all of these risks and benefits into context and allow the consumer or the patient to have a better understanding of what they're signing up for and what they're donating their DNA to.
Thank you for that, Kathy. Tracy, would you tell us a bit about the history of direct-to-consumer genetic testing? And Dr. Blazer also commented on the methodology briefly. So would you tell us a little bit more about that?
Sure. So direct-to-consumer genetic testing really began in the late 90s, when in the United Kingdom, we started to get these mail order genetic testing. Do you want to go back one slide? One more. There, thank you. And over the next probably just about 10 years, the cost of direct-to-consumer genetic testing was really quite expensive outside the use or the availability, accessibility for most people. But around 2007, it reached the $1,000 mark for a genetic test. And it kind of transitioned into something that was more useful or more available to people. In 2010, we had an FDA regulatory proceedings against one of the direct-to-consumer genetic testing companies, where they were making health claims that they couldn't substantiate necessarily. And in 2015, the FDA began to approve these genetic testing reports, health reports. In 2012, I missed a little one in there where direct-to-consumer genetic testing actually dropped to about $100 for an ancestry type report. And if you wanted to get the health related reports as well, that was probably twice that. And now in this day, we're well over probably 30 million consumers that have engaged with direct-to-consumer genetic testing, and all kinds of companies in all kinds of ways. So good question, Yassine, and that gets us right to what are the methodologies that are used for these various types of testing. And I'm just going to really talk about the two extremes, the direct-to-consumer on the one side and the clinic-based on the other. For the health conditions and carrier status reports, these are primarily obtained through SNP-based testing, so single nucleotide polymorphism based testing, and you can see the little SNP chip there. And there are some companies that will do some next generation sequencing. If you get an ancestry-based report, sometimes this is also done by SNPs. Sometimes it is done by short tandem repeat testing, and sometimes by sequencing of regions of the genome, perhaps the Y chromosome, perhaps the mitochondrial chromosome. When it comes to clinic-based genetic testing, occasionally they'll do SNP-based arrays, but primarily sequencing is performed of the relevant area specifically. If this is a specific type of disorder where copy number might be relevant, they will do that type of testing. Or if it's a parent of origin type disorder, then they might do methylation analysis. But primarily, I would say sequencing is the default type of genetic testing methodology for a clinic-based CAP-CLIA certified laboratory.
I think you make a very good point about clinic-based genetic testing, and those of us who see patients in the clinic, we might be using, you know, one or the other. It really depends on the clinical scenario, on the patient's presentation. So it's not a one size fits all. You really need to modify which test you want to choose for a specific condition.
Right.
So Mylinda, would you tell us a little bit more about potential results that the patient might present with in the clinic?
Definitely. Let's go ahead and advance the slide. So the types of information we can get back from direct-to-consumer testing is actually very wide and vast now. It can be anything from, which I think is fun, and I think someone called it recreational genomic testing in the chat, which is a great way to describe it. It's fun, it's engaging, it's interesting. It's things like, do you sneeze when the sun shines on your nose? Do you smell asparagus in your urine? Things that you might actually already know, but it's kind of fun to confirm them with that your genetics actually would have predicted these things. Different types of traits. Ancestry, of course, is complex. I am constantly seeing questions posted on social media about ancestry. Can be a very scary thing to engage in, can actually really challenge your identity. And so it's important to understand that direct consumer ancestry testing is very limited and actually only looking at a very small section of our genome, and so not to overinterpret those ancestry results. So if you ever have patients come in and express concern or angst over that, to be able to contextualize that for them. Kathy mentioned some of the fun nutrigenomics things, which are a little bit silly right now and really have no clinical utility. Things like, my favorite one is what your favorite wines, right? Predicted by your genetics. And then we are seeing increasingly more health and wellness related conditions, from carrier screening results to pharmacogenomic results, hereditary cancer risk results, and adult onset disease. So a couple more examples on the next slide, more specifically. So what are some of the things you can get out there? And right now we're seeing results reported on Ashkenazi breast cancer variants. So these are the BRCA variants. This is really important to understand how limited this test result is, and by no means will ever be adequate for any patient that you see who has a family history of breast or ovarian cancer. So it's very important that if a patient comes in and expresses reassurance that this is false, and they should be urgently referred to a genetic counselor. You can see things now like Parkinson's disease risk and dementia risk. This is not yet something that is necessarily being clinically reported and has not necessarily been determined to have clinical utility yet, because we don't have an intervention to necessarily offer if someone has a higher risk for developing Alzheimer's dementia. So, but you can imagine how scary that could be if you're getting your results at 11 p.m. on Sunday night in your living room, and you have no one to speak to and to contextualize this with. And probably the research really shows right now that lifestyle is so much more significant than these allele risks. So really important to contextualize for patients. But you can find out things that are probably more important and significant, like your risk for developing macular degeneration, right? The #1 cause of blindness in our country. factor V Leiden mutations and prothrombin, the most common variant. Numerous different carrier risks, as I mentioned before, for about 45 different conditions that can be reported. Again, not adequate to safely reassure any family or couple that's thinking about having kids. Should not rely on that. So if someone brings that in as a discussion point, I would definitely consider, again, referring them to a prenatal genetic counselor for broader testing and consideration. Finding out things like familial hyperlipidemia, some of the variants, this is not exhaustive, so it's interesting, but again, not completely comprehensive. And then we're seeing more and more polygenic risk factors, for example, for type 2 diabetes. Again, most likely environment is far more significant than these multiple SNPs at contributing to complex chronic disease development. Let's go to the next slide. So can direct-to-consumer results be used in the management of patient care? The overall answer is no, but it is more complex than that. The first thing I always try to remind everyone is I don't recommend ever scanning a direct-to-consumer genetic test result into a medical chart, because then this becomes discoverable information and it hasn't been clinically validated, right? So we don't want insurance companies making decisions on something that's not clinically validated accidentally in the chart. The second thing is, if there is a health-related result of concern that comes back and the patient shares with you, the results should be considered for clinical validation. As I mentioned before, this can be confusing because these labs mostly are CAP and CLIA certified. It does not mean the FDA has approved these results to be used for clinical decision-making. So if you go ahead and you can find a clinical test, then it should be done to validate that result if it's relevant to your management of the patient. The other option, if you're not sure, again, is never wrong, is refer to a genetic counselor. And we're going to give some resources on how to find genetic counselors in your area in the talk. Only results with clinical validity and utility will have a clinical test available for validation. So if a patient comes in and they're worried about that polygenic risk score for type 2 diabetes, there's no clinical test that you can do to validate that. And that means that we actually haven't proven utility yet on the clinical side. I always want everyone to remember that direct-to-consumer results are not comprehensive and should never be used to reassure decreased risk for any health condition at this stage. So if there's really a concern, again, that needs to be clinically validated. Direct-to-consumer testing can be a great conversation starter, though, with a patient, right? So if a patient brings it in, ask them what inspired them to get the testing done. There might be a whole clinical concern that they have that they've never previously shared with you, and you can then engage on a really great shared decision-making process to really work through that on the clinical side. And last, but really important, raw data that is shared by these companies and third-party interpretation, which is the uploading and interpreting of that raw data, those that are never validated. Those are not CAP and CLIA and are often incorrect. I think everyone on this panel can share stories with you of incorrect interpretation of raw data and third-party and can be really stressful and anxiety-provoking for patients. So immediately contextualize. I pretty much say that any given raw data or third-party result has a 50% chance of being wrong. So, so just contextualize that, and again, evaluate whether this could have clinical importance and significance in management of the patient, and if so, reach out to a genetic specialist who can help guide you through that process.
So I'm going to talk a little bit about direct consumer genetic testing in terms of pharmacogenomics. So there are currently 8 genes and 33 total variants that the direct-to-consumer genetic testing company is offering. 8 genes and 33 variants. This is very inaccurate and very incomplete. So for example, there are over, in one gene, like CYP2D6, there are over 100 known variants that can alter the patient's ability to metabolize or respond to medications. But the FDA approved direct consumer genetic testing for CYP2D6 includes only 17 out of the 100. So the patient could harbor a variant affecting their CYP2D6 enzyme activity and the response to a drug, but their direct consumer genetic testing result comes back as completely normal metabolizer. Sending the direct consumer pharmacogenomic testing from one company to another is going to yield different results depending on what they have on their panel, on what they're testing for. So I would not use direct consumer genetic testing results to alter or adjust my patient's medications. This should be done through clinical genetic testing. There is one caveat. In 2020, the FDA granted a single test for the CYP2C19 gene from a certain direct-to-consumer genetic testing company to interpret drug information for clopidogrel and citalopram. And this is the only variant that does not need confirmatory clinical genetic testing thus far. This list might change with time, but this is the only caveat. I don't expect you to remember this from this talk, but there are several resources where you can go to help you with understanding pharmacogenomic variants. The one that I particularly like to use is the Clinical Pharmacogenetics Implementation Consortium. They don't tell you which pharmacogenomic testing you should do, but if you have pharmacogenomic test results, they tell you what to do with them. And another valuable resource is PharmGKB as well. There are some ethical issues related to direct-to-consumer genetic testing. For instance, your patient might be an adoptee with very limited family history, and they want to know more about their health risks. I can understand where they're coming from, but we have to remind them that the direct consumer genetic testing is limited. If they test negative for the disease risks on the direct consumer genetic testing panel, that doesn't mean anything. They still have to go through national recommendations for screening and preventive strategies. And it might just give them a false sense of reassurance. Direct consumer genetic testing is not comprehensive. Another concern is if a patient was conceived using donor eggs or sperms, and they wanted to obtain health information. Direct consumer genetic testing might be able to connect them with ancestors, with the potential donors, and that would actually violate the donor agreement for anonymity. And would have significant legal and financial implications for the patient. So patients can have the option to actually connect back with their donor egg or sperm bank to inquire about genetic testing that was performed at the time. And you might want to consider referring them to a genetics professional so that they can discuss more comprehensive genetic testing that would be out of pocket for them, but would not give them the false reassurance that comes with direct consumer genetic testing. With that, Rachel, would you tell us a bit more about clinical confirmation, cost, and insurance implications?
Yeah, absolutely. So I hope the one takeaway that you do get from our talk today is that direct-to-consumer genetic testing needs to be clinically confirmed before making any sort of decisions or impacting a patient's care. So that might make you wonder, how do I do this? What is clinically confirmed testing? And how much does that cost? What is that going to look like for the patient? So costs can range from just a few $100s to a few $1,000s, depending on the type of test that you're going to use to confirm. So the least expensive and kind of the most basic test is looking for a known variant. It's a very targeted test. And it's a test that genetic professionals most often use when there's a familial mutation that's known, or a disease that's known to be caused by like a single gene or a single mutation like sickle cell disease. It actually is not the most useful for direct-to-consumer genetic testing though, because there's a chance that the reading frame might be off a little bit for the direct-to-consumer genetic test, so that the mutation or the variant that's identified by DTC is maybe one space off from what the clinical confirmation looks like. So really the next best test to do to confirm direct-to-consumer genetic results are a single gene test. This would be fairly comprehensive and would be able to identify most of the variants in the gene where you think that there might be a variant based on the direct-to-consumer genetic test result. And those are usually $100 to a couple $100 for those single gene tests. The next level of testing that you might consider is a panel test. And this is actually helpful if a patient comes to you with a direct-to-consumer result, and in conversation with them about why they decided to have this testing, you find out that they have a family history of disease. And so a panel test might be a good option to look at multiple genes, not just the one that was concerning based on the direct-to-consumer result. So that's going to be a more robust test that can really be directed by an individual's personal or family history. And then the largest panel, and therefore the most expensive type of test, or the largest type of test, is sequencing, which is exome or genome sequencing, which is essentially where you read a person's entire genome from beginning to end. Oversimplifying that a little bit, but that's essentially what you're doing. And that test can be thousands of dollars. And typically, because of the extreme cost, you do not order sequencing to confirm direct-to-consumer genetic test results. A geneticist or a genetic counselor would order sequencing because there's a suspected rare disease that we just don't know which gene to look for. So that's usually when you use sequencing, not to confirm direct-to-consumer results. It's important to point out that there are some clinical labs that will provide reduced rates for out-of-pocket payers if you do want to conduct a genetic test and you're concerned about the patient's ability to pay or their insurance coverage. Insurance coverage for genetic testing in general is variable, including for confirmatory testing for direct-to-consumer. There are at least 2 private insurance companies, large companies that I know of, that will cover confirmatory testing for specific tests or conditions. For example, the BRCA1 and BRCA2 hereditary breast and ovarian cancer variants that are detected by direct-to-consumer testing. There are some large insurance companies that'll cover that. Another way to get insurance coverage is to confirm that your patient meets guidelines for genetic testing. And that also might require some pre-authorization where you provide that patient's personal or family history. And this is actually a great place for genetic counselors to help out. So if you want to go to the next slide, genetic counselors are healthcare professionals that help individuals and families understand their risk for disease. And one of the things that genetic counselors do is to take a really detailed personal and family history. And with that information, it can identify individuals that meet testing guidelines so that insurance will most likely cover that testing. It's also, genetic counseling is a wonderful opportunity for patients to just learn a little bit more about genetics and to have a one-on-one conversation about why they're interested in genetics, what questions they might have. And here's a slide that has a list of a few places that you can find a genetics professional. The National Society of Genetic Counselors Find a Genetic Counselor tool is really helpful. It can identify genetic counselors that are licensed in practice in your state or in your region, as well as identifying genetic counselors that provide counseling via telehealth and are licensed in the state where your patients live. And I'm happy to answer any other questions about genetic counseling.
And that list that was just up there is in the chat for anybody that would like to follow one of those links. So we do have some questions in the Q&A. How secure are the results from direct-to-consumer genetic testing? What are they doing with those results? And can companies be sharing those results with a third party without the consent of the consumer? Who wants to take that one?
I'll start us out there. So it really depends on which direct-to-consumer genetic testing company we're talking about. And this is where that conversation that Kathy started about consent is really important. Most of the direct-to-consumer genetic testing companies have an authorization form, tiny print, many pages long. And it's important for customers to actually review all of that, because that's where you're going to find out that information of who they share your results or your information with. Most of these companies don't share identifiable information, so it's more like collated information. And some companies give you the option to opt out, but we've seen some companies share the collated results with pharmaceutical companies, for example, to help develop drug targets. Most of the larger direct-to-consumer genetic testing companies have declined to collaborate with law enforcement, so your information is typically safe there. It is not always safe if you decide to upload your results to like a third-party interpretation tool. If any of you are familiar with the Golden State Killer case, like that happened because a family member uploaded their raw data to a third-party company that did collaborate with law enforcement. So the answer is mixed, and to really find that, you have to dig into that authorization form that patients sign whenever they consent to do the testing. Anybody have anything else to add?
One concern that I would have is, there is all of this information, your genetic material is up there. Potentially there could be a hacking that would release all of that information, even if the company tries to follow secure measures. Another one is, will health insurance companies and other lifetime insurance and disability insurance companies try to obtain this information? And I don't know that there is any, we have GINA for clinical genetic testing and clinical genetic information, but, Rachel, would you be able to answer that? Does this apply to direct consumer genetic test results?
Does GINA apply? Is that what the question is?
Yes.
I think it's any genetic information. It's the Genetic Information Non-Discrimination Act. So I think that GINA was established with clinical testing in mind, but my understanding is that it's broad to any sort of genetic testing. And I believe it also includes family history, which is a type of free genetic test, if you will. So GINA would protect direct-to-consumer genetic testing results as far as employment and healthcare insurance are concerned. But as you alluded to, life insurance, long-term care insurance, and disability insurance is not covered by GINA. There are some individual states that have put protections in place. For example, Florida just expanded that coverage so that there's a state law that's similar to GINA that covers all of that. But on a national level, only health insurance and employment applies for GINA.
Okay, another question came in from Azlina. As a healthcare professional, when a patient comes in with results from a DTC test, and I need more information about the actual variants included in the panel to help with my interpretation of the results, is it possible to ask the company for more information about the actual variants they screened?
I can start.
Oh, go ahead.
I could start the conversation on that. Is that if you're talking about a direct-to-consumer company, usually they describe what they've done the analysis on their website, also on the reports. And so it should be pretty clear. Now, whether or not it's 100% clear to you or to the patient or the consumer, if you try, in many cases, in my experience and what I understand anecdotally from other healthcare providers, it's very difficult to get a voice on the phone with these direct-to-consumer companies because they're not set up that way as a CLIA lab would be. So it's not easy to go back and ask for more information of the lab. Conversely, with a CLIA lab, more often than not, and we often will rely on conversations with those lab directors and other providers within it that are helping us interpret complex information from a genetic test report. So generally speaking, it would be what you're able to find on a website and or on the report itself that would tell you what was done. And they often will include some technical information, and they try to make it in clear terms, but it's not always necessarily that 100% clear. And with raw data, when you go to a third party, completely obscure. So it's very, very difficult. And many patients will take and bring raw data to you with all kinds of things that look like they might be important findings, and that can be daunting for a provider to try to sift through.
All right, thank you. Our next question from Malaysia. Welcome, Malaysia. Are there legal regulations on the types of genetic tests that can or can't be performed via DTC?
I can answer that one. To my knowledge, no. In fact, there are direct-to-consumer genome sequencing tests that are currently available. There's even a company that has applied for FDA approval for a consumer-facing version of genome sequencing. So as far as I've seen, there are no regulations on what can or cannot be offered DTC. The regulations come in as to what you can do with those results as far as applying them to clinical practice.
One major problem is that, the cost of the sequencing has come down significantly. So they can offer whole genome sequencing, they can offer whole exome sequencing, but the interpretation is lacking. There is no clinical grade interpretation of the testing. So even if the lab is CLIA certified to perform the whole exome sequencing, whole genome sequencing, you're not getting clinical grade interpretation of the test results, which is really the most important part of the genetic test.
Okay, our next question is, what is the role of the genetic counselor in a DTC genetic testing company? Do they have them, and what do they do there?
I guess as a genetic counselor, I should answer this question.
I think so.
So there are some direct-to-consumer genetic testing companies that employ genetic counselors, and they have variable roles. So some of them work from an educational perspective. So one of the things that genetic counselors are especially trained in is how to communicate very complex information like genetics in a way that patients and the general public can understand. So that's one role that a genetic counselor may play at direct-to-consumer companies, is helping to write reports or helping to develop the language on the website that would be understandable for patients to, or for their clients to understand. There are some genetic counselors, I believe, that also are engaged in the interpretation process, and for not typically for direct to consumer companies, but for the consumer facing, the physician mediated, there are genetic counselors that will provide genetic counseling directly to their clients in that physician mediated form of DTC.
Thank you.
Yep.
Now, our last question in the Q&A. If you have any more questions, please feel free to submit them to the Q&A or to the chat, and we have about 5-10 minutes left before we're done. But one last question that I see here, it looks like there is movement toward the use of polygenic risk scores in genetic testing besides type 2 diabetes. And do you see these becoming clinically relevant in the future?
I can begin to answer that question. So actually, there are a couple of labs that offer clinical polygenic risk scores for breast cancer. And so, yes, we will be seeing more of the polygenic risk scores coming in, even becoming available for clinical-based testing. The problem is that we don't have clinical guidelines as to what to do with this information. What do we do with a polygenic risk score of increased risk for breast cancer? Is insurance going to allow for more robust screening by using MRIs, or are they going to cover bilateral mastectomies for these individuals? I don't know. These are questions that are yet to be answered, and there are clinical trials that are ongoing about the utility of polygenic risk scores that are ordered through clinical labs. So this will change with time as we get more information. Are we going to start offering a polygenic risk score to evaluate if somebody develops diabetes? I don't know. I mean, we already do a screening A1C anyways at multiple age points. Is obtaining that information early on going to change what we're going to do? That's a great question. I think only time would tell as we have more trials and more robust data about the use of these polygenic risk scores. But at present time, sometimes I get referrals for, oh, my son developed type 1 diabetes. Can you figure out why they developed the type 1 diabetes? I'm like, I'm sorry, we don't do this. This is not clinically validated just yet, but maybe in the future.
I can add to that. I think polygenic risk scores really are the promise of precision medicine, right? So this is really where we can take multiple single nucleotide polymorphisms across our genome, plus coupling that with environmental information, right? So what is our activity level? What is our nutrition? What is our environmental exposure? So precision medicine is layering all those different levels together and then coming up with a predictive risk model. And this is what the National All of Us Precision Medicine Research Program is all about, where we're really trying to capture the genomic data of 1 million people across the country and then couple it with all of the environmental and exposure information that's captured in our electronic health records to see if we can get to the point where computer modeling can put these risk scores and all the other data and information together and reach the level of clinical utility. So I think the breast cancer example that you gave, Hriya, is the first place we're going to really see this. And we already have some research projects happening across the country, which are adding the polygenic risk scores to imaging data, as well as environmental and exposure data. But like you said, it's going to be quite a while before we're going to have algorithms that actually integrate this and actual evidence-based medicine and how to proceed with that information in terms of decision-making for advising patient care. So it's the promise of the future, but we're just not quite there yet. And again, right now, all of the data shows that in the category of polygenic risk scores, probably environmental exposure still way more heavily than genetics. And so I would keep going back to patients and reiterating, it's our lifestyle choices. The lifestyle choices are so much more important when it comes to chronic disease conditions, anything beyond single gene disorders.
And one other thing that I'll add, one of the current limitations of polygenic risk scores is that it's based on genetic databases that are not very diverse. So polygenic risk scores can be helpful and predictive of people that are of European ancestry, but beyond that, it is not particularly predictive, which is, I think, where, and I'm glad that you mentioned it, Melinda, the All of Us research study is really trying to recruit a more diverse population so that genetic information and these polygenic risk scores will be applicable to all of our patient population, not just those of European ancestry.
And, another note is that if this is done through direct consumer genetic testing, what is included in their polygenic risk score? And is it going to be the same as clinical grade polygenic risk score? We don't have those guidelines yet. We don't know what should be included on a clinical grade polygenic risk score. We're developing that information. So direct consumer genetic polygenic risk scores are not more valuable than the patient's actual personal history and exposure history and so on.
So we have two questions left, I think. One from Sharon from a while ago that I missed. How do you determine clinical utility without a clear definition or interpretation at this point?
So, so our clinic actually does see patients who bring in their DTC and sometimes third-party interpretation results for this question. And so what we do is we go back to the basics of genetics. We take a really good pedigree, so we get a really good family history, and we find out if these conditions that were flagged on a DTC report or third-party interpretation have any context to this individual and their family. If they don't, that's fairly reassuring. And again, depending on where the report came from, whether it's direct to consumer, which was laboratory validated, or third party, which is not validated at all, may also influence the decision. So I have to say that every test that's come to me from a validated CAP-CLIA certified DTC company, if it had a medical result such as a prothrombin gene mutation, if we validated that, it was correct. But I would say that almost everything that has come from third party, if we actually contextualized it and it turned out it was relevant to the individual's personal medical history or their family history, which is extremely rare that that's happened, and we validated, it was always wrong. So, I just advise going back to the basics first and finding out, is this even relevant to the patient and their family? And again, connecting with individuals and clinicians, whether it be a genetic counselor, medical geneticist, or another skilled provider at delivering genetics care to help you go through that journey if need be. Kathy.
I just want to throw in one additional qualification, and that one of the things that I think we're often thinking about validating findings, but the other thing that you describe in the way you talk about going back to square one and looking at the family history is that very often you'll identify traits that have not been considered, and that there, by virtue of that, you could then take a more informed approach to what you're seeing in the personal and family history, and then apply a CLIA approved test that has been well curated based on what you do see and where there might be risk factors that were completely missed or underappreciated. And so it works both ways, both in clarifying what was found and also perhaps revealing things that were not found. So I think that's the other side of the coin there.
Two things left. The first is, please do evaluate the webinar and send us your feedback. I have put the link in the chat, and you can also use the QR code that's up on the screen, or you can type in the El Paso TTU HSC link that is shown there. And the final question is, do DTC companies have any reviews or ratings that will assist consumers in selecting appropriate, reliable, or ethical companies?
I have seen reviews online, but like any review that you read, there are 5 stars and 1 star for the same company. So as a physician, I personally do not recommend that a patient pursues direct-to-consumer genetic testing for health reasons. If they want to do it for fun, that's their personal choice. But if you are concerned about your health, then you need to talk to a healthcare professional about your concerns, about your family history, and you know, genetic testing is not always the answer.
I think a few concrete things that you can look at for folks or for clinicians that are open to considering direct-to-consumer testing is to look for that CLIA and CAP certification. I think that's the first step. And, you know, the question of ethical, I think that's difficult to answer because the response is going to be different for every patient, for every customer. One customer may be totally okay with a company sharing their results with a pharmaceutical company, whereas another customer is not okay with that, which is where we go back to the thing that we talked about earlier about informed consent and reading that authorization form really closely so that you really understand everything that is involved with the testing.
And that takes us to the end of the hour. Thank you for joining us.
Thank you all for joining us. And if you're interested in genomics education, you can actually join the Intersociety Coordinating Committee for Practitioner Education in Genomics. We would love to chat some more. Thank you again, and have a great day.
Thank you, everybody.